Hi, my name is April Thomas. I am a part of the Safety Council for our psychiatric unit, and I would like to talk to you all today about how to de escalate a potentially violent situation without the use of chemical or physical restraints. Since we all work in the psychiatric unit, there is a potential to encounter violent and dangerous patients. According to Anthony Simi, 2013, in a unit that is full of mental health disorders and personality issues, it is common to encounter aggression and violence. There's always been this stigma that exists with mentally ill people that they could become violent. Most of us tend to think that this is due to their mental status, but in reality, it can be due to a plethora of different reasons. According to Reeve and Welton, 2008, there are genetic and environmental factors that also play a role in someone becoming violent. Some of these risk factors are if the person has previously been violent, if they have a history of military service, substance abuse, depression, or hallucinations, among other things. Although why they become violent is important, it is vital to look at how to effectively calm down and care for this type of person without the use of chemical or physical restraints. To do this, we must first recognize the signs of impending violence. In the article Mental Illness and Violence, 2011, it is stated that a person may become violent if they begin pacing, showing paranoia or agitation. Since a patient will likely show these signs before they actually become violent, the healthcare provider should attempt to de-escalate the situation in this phase. I have 3 strategies to share with you all today that will help to de-escalate potentially violent situations in a safe manner. The first strategy is verbal de-escalation. According to Richmond 2012, this approach involves a loop of conversation that validates what the patient is saying and then stating what the patient needs to do in return. According to Hallett, 2018, asking open-ended questions can also be helpful in this situation so that the patient feels like he can voice his needs and concerns with you. This can help the patient to feel like his needs are understood and help create a rapport with the clinician. The second strategy I have is to move a potentially violent patient into a room with decreased stimuli. According to Richmond, a place free from harmful objects and without extremes in temperature, sound, or color would be appropriate for the patient to be in to calm down. My final strategy involves the importance of physical activity. Physical activity has been shown to be beneficial as a de-escalation technique, according to Hallett. When a patient is becoming more and more agitated, asking them to go on a walk can act as a distraction technique and also help to calm the patient. As a unit, we are going to begin implementing these strategies moving forward starting June 1st. Before using a chemical or physical restraint on a patient, you will be required to document that you have first tried one of these 3 strategies. The goal for this unit is to see a decrease in the number of chemical and physical restraints that we are using. We as a safety council are going to record the current number of chemical and physical restraints that have been used over the course of the past 6 months, and we are going to reevaluate them at the end of next month and then again at the 6-month mark. We hope to see an improvement in these numbers to show that other de-escalation techniques are just as, if not more, effective in calming patients. After evaluating these numbers, we want to have another staff meeting so we can assess your opinions on implementing these new procedures. At this meeting, we will have you fill out an anonymous survey to know how it's working for you. We hope you will all see this as an opportunity to develop better patient relationships, provide more effective care, and see an improvement in your overall satisfaction as well.